It's a hard act to follow, isn't it? And it made me think I'm giving entirely the wrong lecture. I should be talking about another area of my research, which is how rarely mental health services ask people about child abuse and neglect and rape and violence, and how when people do manage to disclose to mental health services, how rarely they get anything useful. So I should be giving that lecture actually, but I won't. I'll stick to what I'm supposed to be talking about. But it did also remind me of, on that topic of how mental health services tend not to ask about what's going on in people's lives. About probably 12 years ago now, I was brought over from New Zealand, where I was working to train 100 psychiatrists in how to ask about trauma. And I asked Jackie Dillon, who's sort of an English equivalent of Lisa, and you can both take that as a compliment, to do it with me. She'd been seriously through similar things to Lisa. And I bored them all to death for all morning with all the statistics about child abuse and its relationship to psychosis and depression and so forth, and how rarely people are asking. And then in the afternoon, Jackie told her story about what she'd been through, and I sat behind and watched the tears well up. And I know which part of that day the psychiatrist would have remembered. So here's the bit you're not going to remember today. But it is important, I think, for people with Lisa's experience and my whatever it is, knowledge or expertise, to work together so that people like Lisa cannot be dismissed as, oh, that's very interesting and inspiring, but very rare. How unusual. What an unusual person Lisa is. And in many ways, I think we'd all agree she is, but what she went through is not unusual. And so when people talk about ECT wiping out parts of their lives, some psychiatrists will say, yes, that does happen, but very, very rarely. So I want to challenge some of that. So here's our agenda, very briefly on the context within which the idea that putting electricity through somebody's brain to cause convulsion could possibly be thought to be a good idea. You've got to have quite a strong and unusual context for that to be thought of as a good idea. A little bit of the history, and then I will bore you to death with what the research says about whether it is effective and what the adverse effects are. And then we will touch on a bit of work that Lisa and I have done together about what people are being told here in Northern Ireland, but also around the rest of the United Kingdom. People who are about to have ECT. So just this is a way to, in one quote, to summarize what's wrong with the medical model. This is the American Psychiatric Association explaining to us why some of us get depressed sometimes. Major depressive disorder is a medical illness, not could be or might be, or one way to think about it is a medical illness, and it affects how you feel, think and behave, causing persistent feelings of sadness and loss of interest in previously enjoyed activities. So it's an illness, and it's a thing that causes you to have all these feelings and thoughts, which is actually backwards circular logic. It's like saying depression is caused by depression. Not depression is caused by all the things going on in my life that are depressing, but it's because I've got this thing inside of me that nobody can see it or measure it or anything, but it's this thing we tell you you've got inside of you that's causing you to be depressed. It can lead, it's a word, but it becomes a causal explanation. It can lead to a variety of emotional and physical problems, and it is a chronic illness. So once you are depressed and have got this thing causing you to be depressed, you will always be like that. And then they wonder why people don't get better. You will always be like that. And it usually requires long-term treatment, and we know what they mean by that. And that's what leads to 1 in 4 people, 1 in 4 women in Northern Ireland being on antidepressants at the moment. That's the context, it's the model. We have turned understandable emotions like sadness and grief and loss into a disorder, and pretended that it explains things. I've written a lot about that in a book with Jackie Dillon, actually, and I think 13 psychiatrists are in there. I mention that because I'm sometimes accused of being anti-psychiatry. It's the diagnostic label that's used for me. I've got anti-psychiatry disorder, apparently, which is a good way to dismiss all the evidence, but anyway. And it's important to just contextualize this also, this focus on the medical model, with what the World Health Organization and the United Nations has to say about it. The predominant focus of care in many contexts continues to be on diagnosis, medication, symptom reduction. Critical social determinants that impact on people's mental health, such as violence, discrimination, poverty, job insecurity, unemployment, lack of access to housing, social safety nets, health services, are often overlooked or excluded from mental health concepts and practice. This leads to an overdiagnosis of human distress, over-reliance on psychotropic drugs, to the detriment of psychosocial intervention. This is not some radical anti-psychiatry patient movement. This isn't new script even. This is the World Health Organization. Similarly, the United Nations, you had a picture of Danius up earlier, I think, Sarah, who was a psychiatrist, who was the United Nations Human Rights Special Rapporteur on the Right to Health. He writes, current mental health policies have been affected to a large extent by the asymmetry of power and biases because of the dominance of the biomedical model and biomedical interventions. This model has led not only to the overuse of coercion in case of psychosocial, intellectual and cognitive disabilities, but also the medicalization of normal reactions to life's many pressures, including moderate forms of social anxiety, sadness, shyness, truancy, and antisocial behavior. This is the context within which some people, only a small number of people, a dwindling number of people, still think, and with good intention, these are good people, still think it's a good idea to put electricity through the human brain with the express intention of causing grand mal seizures. That's the context. The other context, of course, is historical. We've always done weird things to people we decide are weird. Weird disorder. Not fitting in disorder, in this case. We've hung them up from the ceiling. I don't know what this one was about, how that was supposed to make you sane. This is the rotating chair that spun you into unconsciousness, which somehow was supposed to make you sane. The original shock therapy, by the way, was in the 17th century, where they used to stand people with melancholia next to cannons. And at some point, it was supposed to be a surprise. They were sneaked up behind them and lit the cannon, as if they didn't know that was coming. A surprise cannon therapy, and boom, and that was supposed to shock them back into... Again, well-intentioned, but silly, I venture to suggest. This is a bit too awful to look at, I'm really sorry, but this is not so long ago, 1930s, invented at the same time as electroshock therapy, electroconvulsive therapy. We'll perhaps move on, except to say as that evolved, that was the early version of it, literally just putting a metal rod into the brain and wiggling it about. A later version, which was meant to be kinder, was to place radioactive material inside the brain so that the lesions occurred more slowly and people could adjust to it better than having it all done in one go. So we have a history of doing odd things to people, and I have no doubt that in 10 to 15 years' time somebody will be stood here saying, and here's another thing that we used to do to people, but now we realize that was a bit silly. What were the rationales when it was introduced in the 1930s? There were two major rationales. The first was the idea that there was a lot of mutually exclusive theories around in medicine at the time. If you didn't have A, you couldn't have, if you had A, you couldn't have B. And there was a theory, no basis to it at all, that if you had epilepsy, you couldn't have schizophrenia. And ECT was first used for schizophrenia. Used more for depression now, still a bit for schizophrenia. So they were, at that point, they were treating people with epilepsy by injecting them with the blood of people with schizophrenia to try and cure the epilepsy. This is how primitive it is, and you can read this in the medical journals. And the cure for schizophrenia was to cause epilepsy, to cause grand mal seizures, and they tried all sorts of different ways to do that. They had insulin shock, which drove you into a convulsion, and they eventually ended up in electricity. Long story how they got there. So that was one theory. The other theory, because today, of course, the psychiatrists who use it understandably say it couldn't possibly cause brain damage. How dare you say it causes brain damage? That's going to scare patients. You've got to stop saying that, John. The people who introduced it were very clear that it causes brain damage, and that's how it works. Article, Walter Friedman, called Brain Damaging Therapeutics, 1941. The greater the damage, the more likely the remission of psychotic symptoms. Maybe it will be shown that a mentally ill patient can think more clearly and more constructively with less brain in actual operation. Yeah, it's funny. It's a laugh or cry, isn't it? I mean, it is funny, but it's also very, very sad. Another, it wasn't just Walter Friedman. This was there have to be organic changes or organic disturbances in the physiology of the brain for the cure to take place. I think the disturbance in memory is probably an integral part of the recovery process. I think that it may be true that these people have, at the time being at any rate, more intelligence than they can handle, and that the reduction in intelligence is an important factor in the curative process. And some went as far as to say that another way it worked, this brain damage and the memory loss, it was good because it was wiping out traumatic memories. So this is a very bad joke. That's a trauma-informed theory of what's wrong with or what causes mental health problems. But the answer is to wipe out the memories. Interesting. And this isn't talked about today, of course, because it's unethical to have a medical procedure that causes brain damage. So you can't acknowledge that. But that's, when it was introduced, how it was thought to work. And for the first 8 or 9 years, it was seen to work. People were being discharged from hospital, people who had been in hospital for decades with no hope of cure, given ECT, and were being discharged. And so it must have been working, except that the people who were making the decisions about discharge were the same people giving the ECT. So there was a very strong expectation built up. And there is we'll see, there is a temporary short-term gain for some people. But there were no studies done. But fair enough, back then we weren't evidence-based then. I'm not entirely sure we are evidence-based today, but we claim to be evidence-based. We'll look at that in a minute. But there were no studies for the first 11 years. Not until 1950 did they do a study, and the first ECT was in 1938. That study found lower recovery rates for people who had been given ECT than those who were not. And the second one found no difference. Didn't matter, just carried on the same. In fact, they weren't really very good studies because you couldn't do proper placebo studies. A placebo study with ECT is when you give one group of people the general anesthetic and the ECT, and another group of people the general anesthetic, but you withhold the ECT. And we'll see what happens in a minute when you do that. But at that point, they couldn't, because everybody would know who'd had the ECT, because the number of people with broken bones and so forth at that point, this was before they were using general anesthetic. It was introduced after about 10 years, because there were spinal fractures and so on. So to bring us up to date in terms of what the research says today, I've published several summaries of the research in peer-reviewed journals. This is the most recent one. This was with Irving Kirsch, who is the Associate Director of Placebo Studies at Harvard Medical School, who's hard to dismiss as a sort of radical anti-psychiatry person, Harvard Medical School, probably the world's leading expert on placebo studies in mental health. And we managed to get a lot of media attention around this because of the conclusions we reached were fairly, I guess to people who didn't know the research, were fairly surprising. Let's just look at, for a minute, at this slide, which shows that there has only ever been 11 studies in the whole history of this treatment, only ever been 11 studies comparing ECT with sham ECT with placebo. When you look at antidepressants, there will be 500, 1,000, antipsychotics, 1,000, 11. And none since 1985. None for nearly 40 years. In 85 and before, there were these 11 studies. Tiny, look at the numbers, tiny studies. They were all very poorly designed by modern standards, but this is all we've got to go on. 6 of them found no difference between the ECT and the sham ECT. So giving someone the general anesthetic without the ECT was just as effective as giving them the ECT as well. 3 found there was a temporary difference, no long-term, we'll come on to that. And 2 found these mixed results. It's particularly interesting, the one in the middle there, Johnston et al., which is a very famous study, where the psychiatrists saw a difference, but the nurses and the patients did not see a difference. I'm not saying who was right, I'm just saying, isn't that interesting? And then there's the one we're not sure what to make of, Brandon et al. Down here, where they did, often the patients weren't included in you know, do you think you've got better? The psychiatrist said yes, and they did ask the patients, but they decided not to publish the results. So we don't know what the patients thought. You can't do that in science. You can't pick which bits you publish depending on whether you like it or not. But this is measures taken within the first week after the series of ECT. The average number of ECTs in a series is 8. It should have been 6 to 12, between 6 and 12. So after the last one, that's when these studies were. Is there any benefit beyond that? Only ever been 3 studies. You couldn't name a medical treatment that's only ever had 3 studies to see if it has any benefits compared to placebo. Again, the latest one here was 1980. So 2 of them, one found that ECT was a little better than placebo 1 month later. One found that placebo was better than ECT a month later, and one found no difference. Is that the basis for using a treatment on about 1 million people a year still? And the only one that's ever looked beyond 1 month was 6 months. No difference between ECT and placebo. This perhaps wouldn't matter if there weren't any side effects, you know. We'll come on to the side effects. And I also should just stress for a minute that placebo is not a bad thing. So if you've got a treatment and there's no difference between the treatment and placebo, it doesn't mean it isn't working for some people. It means that for those people for whom it's working, it's the placebo that's doing the lifting, doing the work. And there's very strong placebo effects with a very intrusive treatment like ECT. You have a lot of extra attention to what you normally get. You've got lots of nurses, you've got anaesthetists, there's 8 of them, general anaesthetic. So, I mean, nobody does a general anaesthetic without an operation or procedure without knowing that it works and it's going to help you. So you feel like something's happening and something has been done to help you. And you wake up also with quite any minimal brain trauma causes quite a buzz in the brain. We'll call it, that's not a very scientific term, it's called mild euphoria, but so you do feel a bit different when you come around. So it's possible for some people to feel better, but it's not because anything has changed, no chemical imbalance has been improved or anything like that. It's because of the whole procedure. A lot of what us psychologists do is placebo. It's about creating hope and expectations. Nothing wrong with it. Just have to have that. So that's my indirect way of saying this does help some people temporarily. Not usually because of the electricity or the convulsion, but because of the whole procedure have been helped and somebody taking the trouble to arrange all this for you. The conclusions of our big analysis was that the quality of most SECT sham ECT versus ECT studies is so poor, it isn't actually possible to conclude anything about efficacy. So I'm not saying it doesn't work, I'm saying we don't know. After nearly 90 years, we don't know whether it works better than placebo or not. And I think we ought to. The argument given when we challenge ECT psychiatrists about this, they say, well, it would be unethical to do the sort of study that you think we should be doing, John. Because it would be unethical to withhold a treatment that we know works from people who really need the treatment. Which sounds fair enough, until you think a bit about that, that positions them entirely outside the process of science. The whole point of doing placebo-controlled studies is to counteract the tendency that we all have to believe that whatever I'm doing works. So it's like saying, well, I know all the therapy I used to do work. I don't want you to evaluate it or compare it to anything else. That would be wrong to deprive people of me, this wonderful therapist, because I know I work. You can't do that. I'm going to be offended if you do that. But they say you can't do that study, that sort of study, because it's depriving people of a treatment that we know works. We also concluded there's no evidence that ECT is effective for its particular target demographics, which is older women, or its target diagnostic group, severely depressed people, or for suicidal people. And then we took the position that given the high risk of permanent memory loss, which I'll come on to, and the small mortality risk, this long-standing failure to determine whether or not ECT works means that its use should be immediately suspended until a series of well-designed, randomized, placebo-controlled studies have investigated whether there really are any significant benefits against which the proven significant risks can be weighed. Which is close to saying it should be banned, because the outcome of doing that would be that it would be banned. But as a scientist, I think it's a better position to take that we don't know. Do the studies. If we're wrong, and all the people who say it's damaged them and it didn't help them are wrong, and you can show that it's better than placebo, we will have to back off and accept that we were wrong. It is used for schizophrenia. Interestingly, outside of Europe and America, it's used more for schizophrenia than for depression, which was its original target. And they have done some sham ECT, placebo ECT studies since 1985, 3 of them. None of them found any difference at the end of treatment, and the one that did a 20-week follow-up, no difference. So that's what happens when you do sham versus placebo ECT versus ECT. But they won't do it for depression. They refuse to do it. Then there's this whole issue of patients and relatives are often told, well, it's going to save somebody's life. I don't know if they told you or Gary that, but lots of people get told that. And again, there isn't any evidence for that. It's a wish or it's a hope, but there's no evidence for it. So the UK government did a big analysis back in 2003. There is no direct evidence ECT prevents suicide. New Zealand government, these are presumably sort of fairly independent bodies. They're not on one side or other of the argument. They found no definitive randomized evidence that ECT prevents suicide. More recently, last year, this huge study of nearly 12,000 Danish ECT patients, they were found to be 44 times more likely than matched controls to have killed themselves over the following 2 years. 44 times more likely. And yet, patients are told, this can save your life. I suppose it's possible that you might be the 1 in 100 that it does. And I know people who tell me, John, why do you go on about ECT? It did save my life. And my position on that is if somebody believes that it saved their life, then it did. Yeah? The fact that they believed they were better, felt better, and it saved their life, that's wonderful. But it's very rare. It does happen. You've got to weigh all of that lack of evidence of efficacy, against the downside. And do you need research to know that putting 150 volts of electricity through brain cells that are equipped to deal with tiny fractions of 1 volt, that's how our brains operate in terms of our various neurotransmitter systems and so forth, brain cells communicating with one another, tiny fractions of 1 volt, 150 volts. Not all of the 150 volts gets through, so it's some proportion of the 150 volts. But what gets through is between 10 and 100 times stronger than what the brain cells are designed to deal with. It wasn't until 2007 that somebody did a proper study when you take people at the point of ECT and then follow them for 6 months. There was a lot of retroactive studies, sort of looking back, which aren't very good sorts of studies, sometimes the best we had. And they were the best we had until 2007, when Harold Sackheim and his team, a very pro-ECT psychiatrist, who I think genuinely thought, I'm going to put this to bed forever. This is going to show there is no memory loss after 6 months, because patients are told there's a little bit of memory loss and it comes back. And that's true for some people. What we didn't know is how many it isn't true for. He thought he was going to just show that it's very, very rare indeed. He found that there was more memory loss than for the control group at 6 months, by which time it's unlikely to come back. You might get a little bit coming back. Certainly if you've got memory loss at 1 week, you can be fairly hopeful that some of that will come back. But by 6 months, probably not. Impressively, the number of ECTs people had, remember I said a series is usually between 6 and 12, could be 2, could be 10, but the number they'd had correlated with the amount of memory loss. That's a pretty powerful finding. 12% had what he decided to call marked and persistent memory loss, which is a very extreme measure he used. It gets a bit boring statistically, but it's 2 standard deviations away from the middle point. It's quite extreme. So 12% had extreme memory loss, and women and older people had particularly high rates of memory loss. What are the 2 major target groups for ECT? Women and older people. Also, bilateral ECT causes more memory loss than unilateral. Now, bilateral is when they place the electrodes on both sides of the head, and unilateral was developed specifically because bilateral causes a lot of memory loss. That's not why they said they'd do it. They thought, well, let's just do it over here for some, the problem is to introduce unilateral, they had to admit that the bilateral was causing a lot of memory loss. Would it cause less memory loss if they put both on one side? And of course, they put it on the non-dominant, they put it on the side that the effects of which are not measured in terms of verbal memory and so forth. That's a detail. Anyway, the bilateral, as it was kind of known, this study demonstrated bilateral causes a lot more memory loss than unilateral. And in fact, he said at the end, he concluded little justification for the continued use of bilateral ECT because of this. Now, I'm going to show you as we go along some extracts from the International Online Survey that Lisa and I and others are currently running. And 4 times as many people are getting bilateral as ECT today around the world. Sine wave and brief pulse, no difference, and that's important because a lot of the arguments are that brief pulse is less damaging. That's what we do these days. You'll often hear that in the old days, yes, there was a bit of damage, but the way we do it now with the brief pulse and the unilateral is very little damage. And also the memory loss was not related to the level of depression. That's important because another thing people are told is if you do have memory loss after ECT, that's because you're depressed. It's the depression that causes the memory loss, not the ECT. And the evidence is the other way around. That's what happens when you ask patients. There's a number of studies there. How many people had persistent or permanent memory loss 6 months after ECT? This is what happens when the psychiatrists fill out the form. A measure of complete inability to remember. This is just from last year, the Royal College of Psychiatrists in the UK. 1.2% have complete inability to remember. If you ask the relatives, it's 16%. If you ask the patients, it's 24%. These are not small differences. Other adverse effects coming up from our online survey. I'll just draw your attention to the 2 at the bottom, relationship problems. Nobody ever asks, does ECT mess up your relationships? Does it cause you to not be able to do your job anymore? And this is so far 200. We're going for 1,000, but this is at the point where we had 200. Does it cause brain damage? Well, some eminent people have said it clearly does, including an ECT machine manufacturer who includes permanent brain damage in its list of risks. But you still have psychiatrists saying it doesn't, but the people who produce the machine say Yes, it does. And we asked people in our survey, do you think you have suffered brain damage? A lot of people aren't sure, which is fair enough. The mental health, the World Health Organization of the United Nations clearly think people should be told about the risks, the short and long-term harmful effects, such as memory loss and brain damage. And they went on to say that ECT is not recommended for children and this should be prohibited through legislation. Our surveys at the minute is showing that 8% of ECT around the world is on people under 18 at the moment, whose brains are still developing. Mortality, I will not dwell on, except to say that there's this story that has been put out for decades that the rate is 1 per 10,000 patients, just been repeated over and over again in all these different official documents, and the rates are much higher than that, all the actual studies, but still relatively small. It's not the major problem. I've got stuck here now. How do I get out of that? Last viewed. Can't get up to there. I don't want to press the wrong thing, else I'll self-destruct.
I know that well.
Thank you. No. Yeah. Cardiac events. This is, I need to draw to a close, so we've got some time to discuss. So I'll talk briefly about the issue of what people are being told. There is a very important principle, which you'll all know about, called informed consent. People have to be told about the risks and benefits properly, completely. We published a study after Lisa had gathered from Freedom of Information requests what are the information leaflets about ECT in Northern Ireland telling people, as well as we did Scotland and Wales. We had previously done England. And out of 29 accurate statements that should be included in an information leaflet, about 16 in Northern Ireland out of 29 were included, and they had 7 inaccurate statements. So Northern Ireland is about the same as everywhere else in the United Kingdom in terms of not giving accurate information. I'll just give you some examples of that. So the sorts of things that are often left out: the cardiovascular risks, the risk of mortality, the risks from multiple general anesthetic procedures, because people are told this is no more dangerous than having a minor operation, the risks associated with a general anesthetic. That might be true, but they forget to say, but don't forget you're having 10 of them. They're not told there's no evidence of long-term benefits, and they're very usually not told how to access a legal advocate, which is their right. And they are told things like it's the most effective treatment, it saves lives, and it corrects biological causes of depression. These are just, we'll call them untruths, to be polite. Our audit in England of how ECT is generally being administered, interestingly, a 47-fold difference between the trust that uses it the most and the one that uses it the least. Most people, women and over 60, no surprise there. 37% given it against their will, without consent. Very little data being gathered. Very little. 30% using proper depression scales to measure outcomes. 24% using any standardized measure of cognitive dysfunction. And not a single trust in England could provide any data on efficacy or adverse events after the end of treatment. Nobody was bothering to follow these people up at all. Would you want to have ECT again if a psychiatrist thought you needed it? In our survey so far, yes, 21%, no, 73%. I can't think of another medical treatment where the vast majority of people would say, I don't want it again. Maybe there are some, I'm not sure. And finally, the causes of, we're asking people about the causes of the original problem. 75% in our survey so far say that they believe that things that had happened in the previous 6 months contributed to the reason they were given ECT. 38% saying a lot of the reason I was upset or depressed was because of what was going on in my life, mostly loneliness and isolation, major loss. And 40% had been asked about that in their mental health system. And 22% said that the problems that they think had caused the issue for which they were given ECT was addressed in any way by the mental health. And it's a final slide. I won't read all of it because this is sort of along the lines of what can be done about this. Lisa and I are part of the UK ECT Improving Standards campaign group, and we've just written to the Labour Party to include, hopefully to include in their manifesto. We've attached our audits of ECT clinics and information leaflets. We've informed them that a class action case is being prepared by a law firm in London to take the health trusts and the psychiatrists to court about the lack of informed consent, and that we've got the support of 25 MPs, the Shadow Minister for Mental Health, Mind, etc. So there are things that can be done, and I'm going to repeat the fact, to close with, I do think this helps some people. What I'm against is people not being told about the pros and cons properly, so they have a proper choice. And I also think it's a problem that the people who advocate this, and it is a dwindling number of psychiatrists around the world who still think it's a good idea to put electricity through the brain, but it's a significant number still think that. I think they ought to organise research to demonstrate that what they're doing is effective before they continue. To finish with the World Health Organization, United Nations, it's a repeat really of what they said separately over the years. They've now come together to say it more loudly. I'll end with the widespread, this fits with what New Script is going on about and PPR is going on about. The widespread human rights violations and harm caused by mental health systems has led to a legacy of trauma that impacts many individuals and communities and spans generations. And then you think of Lisa's story and the children and etc. Some of the most upsetting stories coming in from our survey are adult kids now talking about when mum came home from having had ECT. The intergenerational effects. Most countries have not challenged long-standing biomedical approaches and compulsory treatment orders. Thank you.